Uh, Shankar, I think amazing job as usual, and thank you very much. And you thought that I was worthy of such great honor, and I'm just moved. Thank you so much. And sir, thank you so much for actually igniting the spark in all of us to have reached where we are today. It's almost 13 years, and today we are at where we are. I think sir has fantastically sort of given us an understanding of the adult way of looking at sleep apnea. Normally you shift up gears, but we will shift down gears for this talk. And we will talk about precision medicine in pediatric sleep surgery. Whether all of us know it or not, whether you want to be known as a sleep surgeon or no, when it comes to pediatric sleep apnea, all of us are sleep surgeons. Because there is nobody in this crowd who does not do an adenotonsillectomy, right? Everybody does a decent adenotonsillectomy. And still today, it is considered the gold standard, but just not enough. So, I think in the next few minutes, I will take you through the fundamentals of pediatric OSA, pediatric obstructive sleep apnea, looking at it through the lens of the newly defined phenotypes and endotypes in pediatric ENT, how it is different from an adult ENT, adult sleep apnea, how do we go forward? Now, I would like to start my presentation with two videos. I would like to you to pay attention to this. Pay attention to this child. Breathing. Facial premise. Stop breathing. Constantly looking at this child, terrified as to what is happening with the child. Here's another child. Stops breathing. And she decides nobody is helping me, I will turn by myself. This is something that most of the home videos that the parents bring us, this I'm sure all of us have seen, and this is pediatric sleep apnea. If you look at the interest that's come in the recent publications from 1983 to 2025, look at the total number of publications that have come in the field of pediatric sleep apnea. Now, it's just not only because the incidence is rising, it's also because we are able to pick up these cases much more. So, genuinely there is increase in incidence and of course increase in prevalence as well. When you look at home, domestically what is happening, data from India, 9.6% of school going children are having obstructive sleep apnea diagnosed. And then when you add conditions like Downs or genetic problems, obesity, craniofacial issues, which are clearly problems resulting from multi-levels of obstruction, the number is going to be much higher in terms of the amount of obstructive sleep apnea in those children. So even this is not a foreign problem, this is a domestic problem. But yet, we all know that pediatric sleep apnea can cause sleep disruption, as you've seen in the video earlier. It causes cognitive impairment, it causes recurrent respiratory tract infections, it causes behavioral problems. But there are a lot of publications that are there, like I showed in the earlier slide. But yet, there are cases who are coming again and again saying that people have been telling them that they will naturally go away, things will go down by themselves. One needs to understand that there should be symmetry between the lymphatic tissue and the airway in which they are sitting. This is the key to understand pediatric sleep apnea. If there is any disharmony in that balance, we are up for trouble. In fact, this is a paper from one of the latest work from in the journal that is Sleep journal, which is very high indexed journal, which basically says that snoring children, even without frequent apneas, may still be at risk for deficit in executive function and attention, which suggests that snoring is a behavioral risk factor for neurobehavioral morbidity. Right? So you don't have to have all those apneas happening in children. And I will tell you why when we talk about in the pathophysiology. You don't have an apnea to happen to develop neurocognitive impairment in children. One of the biggest problems why there is a lot of discrepancy in picking up obstructive sleep apnea in children is because it does not wear the same clothing to every party. Right? Obstructive sleep apnea presents differently at different age groups. For example, if it's an infant, the child is actually having only symptom of repetitive crying or a noisy breathing that we know. If it's a toddler, restless nocturnal sleep. If it's a preschooler, symptoms of nocturnal enuresis which is not getting better and ADHD like symptoms. And if it's a school-going child, excessive bruxism, early morning headaches, these are the manifestations. So it's actually these are puzzles. So if you know one symptom, you obviously are not sure as to whether the child who is sitting in front of you is having this problem or no. The problem here is with actual correct diagnosis. Please don't worry about this very, very complex slide. What I want you to understand is the pathophysiology, which exactly like adults is the same, except for the fact there is one sort of an issue here, the number 3 part, which is called as alveolar hypoventilation, which is the key in pediatric sleep apnea. Otherwise, everything else is same. What is alveolar hypoventilation? Also known as obstructive hypoventilation. And this is necessary for diagnosis of pediatric sleep apnea. So what happens here is that the amount of oxygen going in and carbon dioxide coming out is different. Okay? It is, of course, very, very important that we measure the amount of carbon dioxide that is coming out in children, and hence a level 1 study is what is necessary for the diagnosis of pediatric sleep apnea. That is the gold standard. But there is a lot of information that is now coming out, especially from Australia, wherein they found out that even a level 2 and level 3 studies can be done if you have no access to level 1 study. So why do you need a level 1 study? Because you can measure obstructive hypoventilation. Because you don't have to have apneas, you don't have to have hypopneas, all you have to have is obstructive hypoventilation per breath, which causes an effect in the pre-Brotzinger complex, which is the respiratory center in your medulla of a child, that will actually shift your apneic threshold to let the child breathe or not breathe. Hence, a level 1 sleep study when you do it along with a transcutaneous EtCO2 monitoring or a transcutaneous capnography which measures CO2 is very, very important. So with that kind of understanding of the pathophysiology as to what's happening inside, we can broadly divide kids with obstructive sleep apnea into these 4 kind of broad headings. Okay? The regular garden variety, which is the adenotonsillar hypertrophy, the craniofacial syndromes, kids like Apert, Crouzons, so on and so forth, the obesity phenotype, which is just growing like a beast in our country, and number 4, the syndromic child, that means your CP child, a child with muscular dystrophy, so on and so forth. Now, to dig a little deeper and understanding it further, the phenotypes have further been divided, all right, into kids who are less than 2 years of age, developing children, again your guarding variety between 2 to 12. Why do I keep saying that word? Because that is the age where the lymphatic tissue proliferates. That means your adenotonsillar hypertrophy is at its peak. Children with obesity, which are a different phenotype. Children with Down syndrome, another phenotype. And children with craniofacial abnormalities. Why is all this important? Why should we divide them? Because again, like her sir said, if you do adenotonsillectomy for all of these kids, like having a hammer in your hand and hitting it like with a nail, hitting the hammer with a nail, you will not get good outcomes in each of these. Why? If you look at it, even though adenotonsillar obstruction is the dominant pattern across all the phenotypes, children who are less than 2 years of age, it is not just adenotonsillar hypertrophy that causes problems. Look down in the larynx. Laryngomalacia is a very, very common problem than we think it is. Number 3, it has also been shown that young and obese children have more severe OSA and have more oxygen desaturations happening. So obviously the morbidity is higher. So why so important? If you take an obese child and do a simple adenotonsillectomy, the details of which I will talk to you later, your success rate is less than 50%. That means if you toss a coin, your chance of getting it right is higher than doing an adenotonsillectomy in a very obese child. So we need to remember that in mind. Why? Because we need to counsel our parents. Now when you understand the endotypes now, so what is phenotypes and endotypes? If you understood the lecture Dr. Kashmira gave, phenotype is how the person manifests the problem, whereas endotype is the underlying mechanism. In adults, this is confirmed. People have understood that. But in kids, it is still not, it's still work in progress. But if you see, the basic culprits still seem to be the same. However, in each of these parameters, if you look at them, phenotypically, they will all be different. And that is why marrying the correct phenotype with the endotype so that you can understand the way forward and do the right treatment for these patients. So like any other condition, evaluation is key, dear colleagues. So according to the International Classification of Sleep Disorders, which is the latest classification now, 3 things are necessary: snoring, labored breathing, which is paradoxical or obstructed like I showed in the video earlier, sleepiness or hyperactivity. See, they are not both same. We used to think earlier that children would be hyperactive, adults would be sleepy, but not the case anymore, because there are phenotypes who are sleepy and there are phenotypes who are hyperactive, and behavioral problems or learning problems. It is not enough if you just have these symptoms. In order to make a diagnosis, you need to have an abnormal PSG finding, and it's not enough just to have apneas and hypopneas. You need to have obstructive hypoventilation to make a diagnosis. Again, reiterating the fact why you need a capnograph for pediatric, because a child behavior or a child pathophysiology is not the same as an adult. Once you understand what it is, clinical exam is very, very important. Once the child walks into your room, just check the entire body silhouette. Look at our very nice chubby beam here. He's a nice cute boy who's actually, jumpy around. He's throwing stuff from your table, which is a typical kind of a way the kids are. What we as ENTs have forgotten is that the nose sits on a structure called the oral cavity, which we have completely forgotten. With our nice endoscopes and flexible scopes, we stopped looking at the mouth and started putting scopes inside the nose and started assessing things and grading things, completely oblivious to the fact that the roof of the mouth is the floor of the nose and the floor of the nose is the roof of the mouth. Is as wide of, if the roof of the mouth is wide, so will be the nose. Also assess the dentition. Very, very important. Why? 60% of patients with pediatric obstructive sleep apnea diagnosis have malocclusions. 60%. And of course, our bread and butter, your adenoids and tonsils. So while you go ahead and straight look at the adenoids and tonsils, please look at everything else that is right in front of you instead of jumping at only the adenoids and tonsils. And that is how important clinical exam is. Once you've done your clinical exam, the ideal way is to do a level 1 polysomnography, which I've been talking to you about. That level 1 PSG is gold standard for pediatric ENT. But there is a lot of work that is now coming out, which is saying that you can actually use telehealth supported level 2 PSG, which can also act as a surrogate, because this child is definitely not comfortable and so is the parent, right? So there's a lot of data that is now coming and showing that children actually slept when you did a level 2 study, because a lot of level 1 studies are stopped without completing the full course of it, because either the parent is unhappy or the child has not slept. We can't blame the child with so many wires. But what if you don't have all those magic things like you wires and technology? You can actually use pulse oximetry and use two criteria. You can use a 4% desaturation. If there are 4% desaturations more than 4 in 1 hour in your regular pulse oximetry, or if you have more than 7 desaturations of 3% in a said child, your antenna should go up, saying that this child will definitely require further evaluation. But please exercise caution to put in that formula in kids who are less than 2 years of age. This formula doesn't work well for kids who are 2 years and younger. Another big indicator for us in terms of clinical science is mouth breathing. And those of you who are on Insta, all of you know that the number of reels that have come out on mouth breathing and mouth taping are enormous. That every person started asking us about mouth taping. Please exercise caution, right? But that's another discussion about another time. But clinical significance of mouth breathing is here to stay, because they have found out that the higher the mouth breathing, the more the mouth breathing which they graded, the higher the AHI. They actually measured it. So you can actually use mouth breathing as a surrogate measure for obstructive sleep apnea. This is just out 2026 May. With all that understanding, what do all the kind of associations tell us to do? Adenoidectomy with or without tonsillectomy, which is still the gold standard. Well, the way we do it, things have changed. Some people do hybrid, some people do intracapsular, some people do extracapsular. The question is not about that. The question is, adenotonsillectomy still yields results in pediatric sleep apnea. And if you actually look at their quality of life from a standardized questionnaire, and this has got published in Nature journal, which is one of the top high index journals, that it showed that adenotonsillectomy actually improves quality of life in all those sleep disturbances, physical symptoms, emotional symptoms, daytime function, and caregiver's concern, which is also very important in private practice. So in all the ways, if you look at it, there is a definite impact of adenotonsillectomy. But yet, 15 to 33% of patients actually fail your gold standard therapy. That is a significant number. And that is actually something that all the associations, ours, as well as the sleep medicine associations, as well as the pediatric associations have come to understand. And they said you need to evaluate. So, when do you define persistent obstructive sleep apnea post adenotonsillectomy? Yes, by definition, this is the definition. But you have an unhappy parent sitting in front of you that you said, doc, that this will be all getting better, but my child still sleeps like this. Post adenotonsillectomy. You can see the work of breathing, the persistent mouth breathing. If the parent is coming out to you with these kind of videos post treatment, obviously there is something that we have not done right. If you do a sleep study on Watchpad, it's 3.4, 34 to 5.5. I have done a decent job. Have I? No, I have not. Why? Because one, there are persistent symptoms. Two, the cutoff scale for pediatric OSA is not 5 but 1. And hence, I have not done a good job. Similarly, normal looking child, you would think there's nothing wrong with this child. Adenotonsillectomy done, pre-op 17.7, post-op 11.3. I did something wrong. I didn't do something right in terms of evaluation. So kids like this, all of them looking like normal kids. But there is something wrong with this kid, something wrong with this kid, something wrong with this kid, and this kid, obviously you know something is majorly wrong. So where are we going wrong? Okay? Perfectly looking children, but somewhere we are going wrong. We can start off with this. For a child whose video actually got and it was done for this sound. We obviously know something, right? So, if you have a child and you have not done what is right for the child, obviously there is continuous upper airway collapse happening, but the consequences, if you look down, are ADHD, hyperactivity, impulsivity, inattention, right heart failure, all happening significantly in front of your eyes because we have not evaluated properly. Yes, we would like to have all our kids like this, but we can't choose which child will come or just be like this. And which child will come with a combination of this, this or this. Any of this combination can actually also result in persistent obstructive sleep apnea, or this for that matter. So there are a number of children following adenotonsillectomy, and unfortunately, like in an adult, where you can post procedure, you can say that, okay, I have brought your disease burden to this level, beyond this you use the CPAP, or I'm sorry, I couldn't do a job, good job. The patient might understand you can't put a CPAP on these patients, because I will talk to you further. You can't give an autopap to a pediatric sleep apnea patient, which is very easy in an adult, because they are all smart machines. You cannot, and I will tell you why. So, with all these underlying things, all the big wigs sat together and decided that something has to be done. So the American Thoracic Society has now issued a clinical practice guideline for persistent sleep apnea, saying that if you have children who have severe symptoms pre-op, or you have a child who is syndromic, you have to do a sleep study. Now, what you do is based on what your clinical evaluation is. So, who are these kids that you cannot take every child and do a sleep study? The garden variety, you can't do a sleep study for every tonsil adenoid hypertrophy. So, who are these kids? So, please remember that kids who are less than 2 years, symptoms are not matching the clinical findings. Kids who are syndromic, remember the phenotypes I spoke about? Those kids, it is always a good idea to understand the physiology, not just anatomy. See, we are having persistence of about 33%. Why? Not because we are not able to pick up the anatomy. It is because we didn't understand the physiology, and the sleep study helps you understand physiology. So, when is it significant? So you have done a sleep study in your post-treatment patient. When is it significant? So by definition, you have done a tonsil adenoid, and if the AHI is more than 1, that means there is treatment still to be done. But will you take every child back to the theater? Is there scope for medical management? Yes. But in whom? In kids where there is mild disease, you can try things like Montelukast. Why? Because tonsil and adenoid tissue are rich with leukotriene receptors, not histamine receptors. And that is why an antihistamine will not work as well as a anti-leukotriene receptor along with your intranasal corticosteroid. But if the residual AHI is more than 5, you need to do something ASAP. Why? Because there is neurocognitive consequences. That means the child is going to have permanent neurocognitive impairment because you have refused to act. Hence, it is important to stratify. So, what about questionnaires? Now, in the little time that we have, especially this is important in persistent OSA post-adenotonsillectomy, because you can't ask all these questions. You are in a busy OPD, there are 20 files sitting there, you still to do, a child and the parent both unhappy sitting there, procedure done by you, somebody else, your colleague, your enemy, doesn't matter. But hand over a questionnaire so that you can understand what the parent is trying to tell you. Because sometimes you may not be in the right frame of mind to understand the parent's concerns. So, these are two validated questionnaires that we use in pediatric sleep apnea practice. So, when you have a child with persistent sleep apnea, if you don't treat them, there are a lot of problems that are happening if we don't get to the root cause of this problem. The spectrum goes from cardiovascular problems to somatic growth retardation. And all of that blood is on our hands if we do not evaluate it properly. There is data to show that recurrent apneas in children can actually cause significant cortical atrophy. So that is significant. If there is cortical atrophy is happening and you're not doing anything, it is our fault that we have not done what is right for these patients. And needless to say, what is happening below, that is in the upper jaw. Because of persistent mouth breathing, the upper jaw is becoming narrow, the tongue is unable to sit where it needs to sit, the nose has become extremely narrow because the air is still not going in. But let's address the elephant in the room, which is, if there is a high arched palate and the upper jaw is going up, what will happen to the septum? The septum will have a septal deviation. So it is also very important to address septum even in the pediatric age group. There is a lot of data now there to do that. But you necessarily don't have to get your hands dirty every time. You can take the help of our pediatric orthodontic colleagues who are in sleep to actually give us something called as a rapid maxillary expander, which can actually expand the jaw, and as the air goes in, because form follows function, the airway gets restored, and then there is not much of buckling of the upper jaw anymore. So if you're not comfortable, you can definitely refer it to our pediatric sleep dentists. So here's a paper that got published in 2018, and this is in the laryngoscope by the Trilogic Society Best Practice. And they have actually said that pediatric septoplasty may be safely performed without significantly affecting the future of nasal and facial growth. However, you can't address a pediatric septum like how you address an adult septum. There are certain things that you need to avoid, but since this talk is not about that, let's not talk about this. But there is an option to send it to a pediatric dentist. But can we predict our potential failures? What about your child who is sitting there? How do you know? Is this child going to be successful or is this child going to be a failure for you? Please remember that if you have a child who is syndromic or craniofacial anomalies, obese, or having allergy, this is a child will bring your success down if you do an adenotonsillectomy. So if you have any of these children sitting in front of you, start with a sleep study. What about biomarkers? Dr. Vignesh spoke beautifully about biomarkers in adults. Now there is validated data that you can actually use highly sensitive CRP as a biomarker for systemic inflammation in children with adenotonsillar obstruction or persistent OSA for any particular reason. Dealing with persistent OSA is of course a challenge. Why? Because it's not just the child you're dealing with, it's the grandparents, it's their cousins, and the entire family and the village will walk into your room once the child is not fixed. So always involve a team. Now is the time you don't have to do all the bench lifting, don't be a hero, involve a team, because persistent OSA management is a team effort. So these are all the risk factors that can actually result in residual OSA. So I've highlighted all of them. We've spoken about the others before, except the ones that are children under 3 years and older age group with asthma. So can we try conservative management? I have said so, but the first one is obesity. If you have a child who is obese and you want to do an adenotonsillectomy, do not promise a cure for that particular patient, because again, like I said, it's a team effort. Here are some differences between children who have pediatric OSA because of obesity and not having obesity, and this is how they are different. Look at depression. Depression for a child who is obese and having adenotonsillectomy is common. It's something that we don't look at, but it is there. So, as opposed to a child who is running around your clinic, this child is nice, fat, and sitting in front of you, tired and depressed. Yes, you can use Montelukast, but please remember that a black box warning has been issued for the use of Montelukast because of suicidal thoughts that it can give to a child if you give it for a long time, especially with history of behavioral disorder. And we know that most kids with obstructive sleep apnea will have some behavioral disorder. So you should be very, very careful and be aware of it and discuss it with the parent. Another problem which we all know is vitamin D. Vitamin D is also an important parameter that you should look for in kids with pediatric obstructive sleep apnea, and always check, and this has been published in JAMA. What about CPAP? Why can't you just give CPAP? You can't, because all the calibrations for the latest machines are for adults, not for kids. So you need to do a fixed titration, give a fixed pressure to these patients. So you can't keep giving CPAPs for failures. So another important thing about giving CPAP is that there is no literature showing improvement in quality of life as well. What about myofunctional therapy? In adults, it's a dictum, but in kids as well, you can actually give small exercises and make them do it first time yourself, and then probably later you can ask the parent to do it. So what do you do with all these kids? Well, you can actually do these three things. Do the sleep study, do a CineMR or FLP, and do drug-induced sleep endoscopy. And of course, the next talk, I didn't want to steal the thunder away from Jay, but he will talk. This is his favorite, and after he started doing it, I've started using CBCTs with computational fluid dynamics, which is actually giving us two things, soft tissue and skeleton at the same time, and you can actually evaluate with color where the obstruction is happening. So this is CBCT with computational fluid dynamics. So DICE is very, very important post your adenotonsillectomy and your treatment has failed. The only difference between adult and pediatric is that you need to assess the larynx and you need to assess the nose and adenoids as well. So it's very easily done, but you need to have a whole team there because these are syndromic children. So once you identify all that, what is it that you can do? Well, there are variations of procedures that you can do. This is expansion sphincter pharyngoplasty, wherein you actually take the palatopharyngeus muscle and create space there based on DICE. One of the commonest causes for persistent OSA is pediatric lingual tonsil hypertrophy, so you need to grade them and do adenotonsil and do a lingual tonsillectomy. But what is your endpoint? Your endpoint has to be your vallicula, which has to be clear after lingual tonsillectomy. Now, what about laryngeal OSA? Very few words. There is something called a stage dependent laryngeal OSA. That means in a particular stage of sleep, the child can have laryngomalacia, and in these kids, doing a supraglottoplasty with anything, whether you want to use coblator or you want to use laser, actually works and reduces AHI. Especially look out for supraglottis problems in children below 2 years of age. What about persistent nasal obstruction? Like I said, 60% will have malocclusions. This is a child, my own patient, before treatment. After treatment, you can see how much the space has increased. And once the space has increased so much, the nose space also increases. And this is a rhinomanometric measurement of a child, how much beautifully the airway has improved once you have done the maxillary expansion. So, in a nutshell, you have to follow these guidelines to basically sort of understand how you treat a child who is suspected of sleep-related breathing disorder. Symptoms, sleep study, interventions, sleep study again, not in all cases, but if you have failed, if your PSG is more than 5, do a DICE and adequately treat these patients. So dear colleagues, I won't torture you anymore. Adenotonsillectomy is still successful in majority of the patients. A subset of pediatric patients will continue to have obstructive sleep apnea after adenotonsillectomy. Use DICE, use CineMR. You can identify the anatomical causes of residual obstruction. Use your sleep study to understand the physiology that is giving rise to that particular endotype. So I would like to finish with this particular saying from Emerson. To know one life has breathed easier because you have lived. This is to have succeeded. And this is every one of you out there, dear colleagues. Thank you very much.
So the wonderful talk by you, sir. So we used to get references from the dentist because of malocclusion. First go and check with the ENT to see whether there is adenoid. Is it after the malocclusion they'll settle down, we have to do adenodectomy, or after adenodectomy they have to do this?
Excellent question. We need to work together. So unless you clear the obstructions, the malocclusions will still remain. You have to clear the static blocks, allow air to go through it, and then let the pedodontist work their magic.
Thank you, sir.
Thank you.
So one more question regarding allergy as a predisposition in lot of cases.
Yes.
How long you want us to give nasal sprays, especially after post-adenotomy?
The recommendation is 3 months, but please remember, in children with behavioral problems, and nowadays people are talking about cumulative steroid use in their entire lifetime, not to cross more than 500 milligrams. So if you finish the entire lifetime's course in 3 months, we'll be in trouble. So we need to be careful.
It's a wonderful talk, sir. Thank you so
very
much.
much.
Thanks a lot, sir. I request the chairpersons to the stage for felicitation. I request Dr. Srinivas Kishore to felicitate the chairperson, sir.